Good afternoon, ladies and gentlemen. I want to welcome you to the Lifebulb Columbia Transplant Patient Education Series. And we're delighted today to have on our panel Dr. Rodrigo Sandoval, who is Assistant Professor of Surgery and Director of Pediatric Transplant Surgery at Columbia University. Dr. Heather Morris, who is Assistant Professor of Medicine and our transplant nephrologist, and Brian Runge, who is the Chief Donor Coordinator for renal and pancreatic transplantation at our institution. The moderators today will be myself. I'm a professor of surgery and a former director or director emeritus of the renal transplant program at Columbia. And Karen Hehenberger is an MD, PhD, and a CEO of Lifebulb, and also a recipient of both a kidney and a pancreas in the past. So she's highly experienced in this area. The subject of today's discussion is going to focus on the issue of living organ donation in terms of kidneys, particularly. And we will focus on that, and the questions will be directed to the panel by the moderators. And we also welcome questions from the audience. You can either raise your hand, or there's a little hand on the bottom of your screen, or you can actually type into the chat, and Dr. Hehenberger is going to interpret this back to the panel. So I welcome you to this. Feel free to collect your questions and ask them. That's what we're here for, and there is no such thing as a silly question as far as we're concerned. Karen, would you like to add to this?
Yeah, no, thank you so much, Dr. Hardy, and we're really excited to be co-hosting this seminar today. I also want to thank Veloxis Pharmaceuticals for sponsoring the series of educational seminars. It's really a great opportunity for our patient population to be so close to experts in the field. And we really aim to present with you, to you, a range of experts, as you can see here today, again, reflected by our speakers. This is really important to us. Again, as the CEO of Lifebulb, we are a patient empowerment platform. We believe very strongly that patient education is foundational to how to live better with a chronic disease, and transplant and organ transplant is clearly a condition that is lifelong. So the more educated and the more I think aware of your opportunities and the different future prospects that you have is really, really important. So take this opportunity, and also I would say please do put your questions into the chat. I think the raising of a hand may not be possible right now, but put your questions in the chat. And you can also continue with the conversation afterwards on transplantlife.com, where patients can continue to converse about this specific topic. I know this topic is ranging really from real questions, practical questions, medical questions, financial questions, to also emotional ones, because it also involves perhaps asking a person to give you an organ of theirs for you to continue to live a good life. So we encourage you to bring out all those questions. So thank you.
So let us begin with the first question, which really focuses on the idea of when should a patient select a living donor? What point in their renal failure should they start looking for a donor, and how should they do that? And I will ask Dr. Morris to start our discussion on that.
Sure. I would say as soon as transplant is something that's on the horizon, it's good to start thinking about living donors. And the reason for that is that pursuing a living donor allows a recipient to minimize their time on dialysis and sometimes completely avoid dialysis. So those are very important incentives. I think that something I tell my recipients is that people can't help you if they don't know what's going on. So it's important for kidney transplant recipients or pending recipients to let people know what's going on with them, that they are undergoing a transplant evaluation process, and sort of let people in a way that might seem a little scary sometimes, but again, people cannot help if they don't know. And I encourage people to really let people in from a variety of networks, whether it's their own family, friends, church groups, social groups. I think casting as broad a net as possible is helpful. And social media can be a powerful tool. Several of my patients have found donors successfully through social media. And I found that the most successful endeavors there have been through really sharing the story of who they are, what they do for a living, as much texture about their life and their connections and their roles as possible, to help people understand what a transplant would do for them and how it would allow them to function better in their roles.
So I think that you also emphasize, I think correctly, obviously, is that you cannot be ashamed of your disease. You really have to declare it in any nice and social way to everyone. Dr. Sandoval, any further comment on this, particularly in terms of perhaps the importance of so-called matching that everyone is always concerned about? Are we really that concerned about matching in a living donor situation?
Thanks, Mark. So this is it's somewhat of a complex question, but we can try and simplify it, right? So first, just to piggyback on what Heather had to say, I completely agree. Once transplant is in the horizon, the pursuit for a donor, if it's not readily available, should start, and that's going to be different for every patient. Some patients are gonna be lucky enough to have a very rich social environment with multiple potential donors. Some people would not have that luxury. So then the earlier they start their pursuit for a live donor, the better. And another very important point that I think Heather made is social media can be a very powerful tool. And when trying to reach out to a large group of audience of potential donors, it's important. And what we have seen, people that have succeeded with their stories and their narratives, is to emphasize more so than in the disease process and the suffering, which obviously occurs in the scary component of the disease, is to emphasize in what their vision, their future, their life is like, what they're getting out there in personal and allowing people to interact with their life at some level so they can connect. So I think that's very important. Now, in terms of the matching, there's a lot of misunderstanding of this, but I would say to have a live donor, even if it's not a match, can be very successful in ultimately resulting in a transplant. So I would think that the most important part is to have someone that is willing to donate, because there's several ways to deal with a mismatch, either by tissue or blood type. But if someone has a willing living donor, they're much more likely to get transplanted. I would say that not necessarily 100%, but very, very, very high chances of getting transplanted in the short period of time.
Can I ask a question, a follow-up on that, to I guess all three of you? If a person is looking, has options for several different people to provide a kidney, how should they assess those different alternatives, considering the fact that a kidney may not last lifelong, a transplanted kidney may not last lifelong for the patient?
So before you all answer, let me just interject something that is really important. It sort of hangs in the air. You all have to realize, that's to the audience, is that a living donor kidney is twice as good as a deceased donor kidney. And by that, I mean that the so-called half-life of a deceased donor kidney is of the order of 9 to 10 years, which means 50% work up to 9 to 10 years, and 50% may work much longer, even 20, 30 years sometimes. And the kidney can reject early at 2 weeks, at 1 month, at 2 months, anytime. With a living donor, a living donor, the half-life is 18 to 20 years. So it's a long time. It's exactly twice as long as a deceased donor kidney, except in the situation where there is so-called identical match in a sibling. So it has to be a brother or a sister from the same parents with the same genes as the recipient. And there the half-life is of the order of 30 years. So it's much longer, but that only occurs in any large family in about 25% of the time, 1 out of 4. So that's the level field to start with. And now the question is in the air that Karen asked. So why don't you take that on, Heather?
Sure, I can start. So there are a lot of factors to consider if you are in the lucky scenario of having multiple donors to choose from. I think one general principle is that all else being equal, a younger donor is preferable. So that is one sort of overlying principle, I would say.
Can I interject? Can I ask you, how young is young? How young will you go?
Oh, well, that's another great question. I mean, technically, if you're 18 or above, you're an adult. But as a nephrologist, I'll tell you that I definitely am much more protective of and nervous about donors in their, late teens and 20s, because they have so much of their life left to live that is unknown. So, for example, the 55-year-old donor, 60-year-old donor is easier to approach from my perspective, because most of the comorbidities that they were going to develop would have developed by now, right? So I have much more data on which to make my decision as far as their risk living with one kidney going forward. Whereas a 20-year-old, they have a lot more of their life that is still unknown to me. And they might have family risk of family history of diabetes, but they don't have diabetes yet because they're 22. But that's in my mind when I'm considering their whole sort of risk package moving forward with a single kidney. So from my perspective, it's easier when I'm evaluating older donors because of what I just said. But from a recipient's perspective, all else being equal, a younger donor is going to have greater longevity. And so that would be preferable.
If I'm 6'3" and my wife is 5'3", should I worry about getting a kidney from her?
That's an interesting question. There are some cases of size mismatch where the kidney that was doing fine in someone tiny doesn't provide quite enough mass for a very large person, I would say that's rare. And, you know, in that case, the creatinine in the recipient might end up being higher than we would otherwise expect. But I just want to emphasize that overall, a living donor, whatever the case, should be considered and should be utilized. So I think if we're able to split hairs about age and about matching, that's great, and we can do that. But overall, any living donor is going to almost always be better than waiting for a deceased donor.
If I'm a woman who is 30 years old, should I worry about having babies afterwards?
You shouldn't worry about it, but you should know certain things that I would counsel about if I were evaluating a donor. So what I tell women of childbearing age is that it is safe to get pregnant after kidney donation. We have literature on outcomes on women who become pregnant after donation. And we know that there's a slightly higher risk of gestational hypertension, which means high blood pressure during pregnancy. We know that there is a slightly higher risk of preeclampsia. And if you take two groups of sort of similar health people, let's say young women of childbearing age, and you say, well, half of them donated and half of them did not donate, but they're very similar in their health characteristics, very healthy. All of them could donate. The group that donated will have about an 11% chance of developing high blood pressure during pregnancy or developing preeclampsia. And then those things will develop in about 5% of the non-donors. So it's 5% versus 11%. So what to note there is that there is an increased risk of gestational hypertension and preeclampsia, but it's still rather low, 11%. So
they should just, so the major advice you would give them is that they really have to be followed by a gynecologist. Well,
I would advise any pregnant.
Very carefully. But they should be perhaps more careful than they would otherwise.
Yes, it's something that should come up in your first prenatal visit, for sure. That you've donated a kidney, and then. But it's important to note that in the studies we have available, there are no differences in the fetal outcomes in kidney donors. So there's no difference in the health of the infants that are born. No difference in preterm labor.
So that brings us to just an interesting question on the kidney in a person who is the size again. So if you have just one kidney, the child is not affected, but the person with the one kidney, of course, can have some impact when their system is being pressured. Being pregnant, you need to increase your blood flow by almost twice, right? So you need more kidney function. In a person who has given up a kidney, per definition, their creatinine probably increases a little bit, but does that impact the GFR necessarily?
So a kidney donor's GFR will be lower than before donation, right? So is that the question? Is because their creatinine is higher, does it mean their GFR is lower? Yes, it does. We know that. So if you think about if you have two kidneys and you give up one, you might expect your GFR or kidney function to be half of what it was before you started. But just because we had two and now we have one. But we know that's not the case. And there are sort of immediate changes that happen that are hemodynamic, that are blood flow related, where the remaining kidney actually starts working a little harder almost immediately. And then it continues actually to recover function over the next months to even years. Looking out, you can see it continues to recover function. And we know that kidney donors end up recovering about 70% of their initial function. So their GFR is lower, but it's not half as low. It balances out somewhere in between because the kidney is amazingly able to compensate and work harder.
So as I understood in the past, we are all born pretty much with the same number of nephrons in the kidney, whether the kidney is in a 5'3" or a 6'3" individual. So it doesn't it then become only a matter of growth of the individual little nephrons, of the little factory that does all the work in a kidney?
Exactly. You don't grow new nephrons, unfortunately. We're not starfish. We can't regenerate, but we the ones that we have, the filters that we have, hypertrophy and filter more than they did before.
They become a little bigger factory.
Mhm.
So they work a little harder, a little better.
Mhm.
So it really doesn't matter too much if you have a 5'3" wife to get a 6'3" recipient.
Right. Usually not in a way that would make you not pursue that particular transplant pair. It just might change our expectations for the recipient's creatinine going forward.
Right, of course.
I think it's important to know and remember that it's very rare that I've been doing this a while that we have the discussion of, oh, is this donor too small or too big for the recipient? It doesn't come up much, but every once in a while it does, because maybe they're donating to a very small pediatric patient, or it's a really big husband and a really tiny wife. But when it does, we discuss that in our donor conference that we have with our whole team, and also the recipient conference, to say, hey, is this the right thing? And it's something really people shouldn't really think about, because when you start you're not in medicine, and you start playing the game of ruling your donors out because you think we're not going to approve them, or they're too big or too small, that's our job. Send them to us, because guess what? When we do run into that very small situation, we might approach the wife if she wants to donate to her really football-sized husband, and we're said that's not a good idea, but you can indirectly help him by getting a transplant. She then donates to me, and my donor, who's too small or maybe a different blood type, donates to him. So she indirectly got a transplant just by, instead of backing out or never coming forward, now we've gotten an extra person transplanted in a swap. So it's wise to know that. Don't start ruling people out. What you think they may have medical problems. Yeah, they may have some medical problem, but that might not be a barrier to donation.
That's a great point. Very, very important point. We have a question from our audience here. Actually, a person who is going to be a donor. I'm going to be a donor. So I would say really a wonderful, wonderful thing for this person. And it's saying, I'm worried about recovery time. How long does it usually take the donor to fully recover? Maybe Dr. Sandoval.
Thank you. So that's a very good question, and that comes often. How long is it going to take? And as much as we would like to simplify the answer, unfortunately, in medicine, things sometimes are not that simple, right? But I'm going to try to do my best to explain it, to have the question answered to the best of my ability. So we're different individuals, and it's very, very different from person to person, the experience. Overall, I would say patients spend in the hospital a couple of days, meaning 2 or 3 after this surgery. Then they go home to continue to recuperate. They typically come to the hospital for an appointment post-surgery about a week out. At that point, they're still not fully recovered. But they're feeling much better. Pain has improved a lot. Their regular functions are back to their usual. They go to the bathroom, they shower, they do their activities of what we call of daily living. And back to work, on average, I would say somewhere between 3 and 4 weeks. Now, we have extremes of people that do very different, right? So we've had individuals, I've seen individuals that were ready to go to work the next day from surgery, and there they went. I had a very, very dear patient that was hiking the Himalayas 5 weeks out. So that is someone that was in his 60s. So and then we've had patients that sometimes takes them several weeks to fully recover. But I would say for heavy activity, for gym type activity, perhaps somewhere between 4 and 6 weeks is what's needed. be back to that. If that kind of answers the question. But again, everyone's different. Helps a lot to come into the operation in a strong status of health. And, you know, so sometimes people come in and they prepare, you know, they feel fit, they're doing well, they're active. And those patients tend to bounce back a little quicker.
Thank you. I think the person who's asking says thank you. That answer is very helpful. So that's great. Thank you.
No problem.
So, Rodrigo, as long as you're on this whole issue of how people feel afterwards, can you comment briefly, and Heather may follow, about the risks of the procedure itself for the living donor? Are there any significant risks after that workup? You already mentioned the fact that if they come in good shape and exercise and prepare for the operation, they come out they finish the operation in great shape and can return to whatever they wanted to do a little faster. But the major thing is, what are really the risks of the procedure, and what are the long-term risks? Perhaps Heather can comment on it after you do.
Right. So I think, you know, the risks for the procedure for the donor can be categorized, right? And I don't think they're the same for everyone around again, but you know, we could categorize them as surgical risks, medical risks, psychosocial risks, and financial risks. And so I think that the donors need to be aware of all of this and counseled about them. In terms of the surgery, which I think is what you're asking me specifically
No,
about.
everything. I think you summarize. I think that it's very important to look at all the aspects.
Okay, so I can start by the surgical risk
Right.
and try to be brief. So unfortunately, there's no 100% risk-free surgery. So this operation is not different than others. You know, surgeons, we work hardly in perfecting our craft and our techniques. Despite of that, you will encounter a small percentage of cases that will result in complications. Majority of complications in the laparoscopic kidney donation are mild. However, there's a few ones that can be severe, even life-threatening, and very few even, you know, leading into the death of the donor. The death of the donor, you know, it's somewhere between 2 or 3 and 10,000. And that's a number that hasn't changed in decades for now. Unfortunately, it's one of those little statistics that won't change. You know, if there's a death, it has to be 10,000 cases for that death to kind of like change in terms of statistic. But, you know, it's uncommon. If you want to have an idea or a perspective of what mortality is in surgery, like about 18 out of 10,000 removals of the gallbladder result in death. So it's comparatively speaking a low number, based mainly in the fact that usually it's performed by well-trained surgeons, and usually it occurs in individuals that are in good health as well. Now, more commonly, the operation which is performed laparoscopically means with small incisions. We use ports and operate from the outside using a camera, insufflate the belly. So it's what we consider a minimally invasive operation. Needs to be sometimes converted to an open approach, which we consider a complication, and that happens in about 1 in 200 cases. So that becomes a little more real, I think, for donors. It's still a small number. Complications In males, for example, there can be testicular swelling, testicular pain, as high as 1 in 30. So I would say those are.
But it goes away.
Some of the complications. It goes away. Now, in terms of long-term complications, midterm complications, hernias can occur, and that's why we'll instruct not to do certain activities immediately after surgery. But despite of that, certain hernias can occur, not very frequent. And then laparoscopic, every time there's surgery in the abdomen, laparoscopic or not, inadvertent injuries can occur as well to other organs. So that can also result in complications that could be pervasive, and they can be they can result in prolonged hospital stays and in morbidity. So those also are rare. Those do not occur frequently. Less than 1 in 100. And in terms of medical complications, and there's a slight increased risk of developing high blood pressure, which has been studied, like Dr. Hardy mentioned. There's also a slight increased risk of developing end-stage renal disease as compared to non-donors. And this has been also extensively studied, but the risk again is very small. Seems to, for the majority of the population that donates, less than 1%. Psychosocial risks, there could be multiple, but I think that I would like to highlight for potential donors. We look into individuals that have had a history of depression, even more so suicidal attempts or episodes, because we know that post donation, patients that are susceptible can develop depression, and there's some particular individuals that are more at risk of that, including in the rare event of bad outcomes in the recipient, can result in severe depression of the donors. So that is also another important thing to assess and kind of like be prepared for.
So on average, it really looks like it's very low risk of medical, surgical, psychosocial complications to the donor, and the upside, of course, on the psychosocial side is that this person becomes a hero in many people's minds, and especially probably the recipient. I know in the case of my father, he's my hero more than before. And
absolutely, I would say if we would have, and this has been asked to donors in the past, if they could do it again, the vast majority, if not practically all of them, would say that they would do it again if they could.
And most importantly, I think in relation to that, the ones where the kidney actually, for one reason or another, was rejected or lost, those donors also would do it again.
Yeah.
Yes.
Which was really one of the critical findings in a large study, actually.
There's an interesting question here. So someone is asking how long a living donor kidney could live to be. So the donation should not interfere with the longevity of the individual, right? So the only case that I can imagine that they could interfere with the longevity would be, obviously, if there's a short-term complication that results in the death, or if they will develop end-stage kidney disease, which could certainly compromise the longevity of the person. But the vast majority of individuals would live, pretty much what they would live with 2 kidneys. That's at least what the science seems to say to us.
I remember studying this before, asking my father to do it because it's a big ask. And I remember seeing studies showing that kidney donors live longer than non-kidney donors, but of course, they're also pre-screened.
They're pre-selected, yeah.
to be healthier than those who are not donors. So it kind of is a flawed study.
Correct.
But yeah.
You know, and then donors donate and they are worried about themselves even more so after they donate because they are missing something. So they try and eat healthier, they exercise.
Yeah.
So of course they try a lot harder afterwards. Just to add on to Dr. Sandoval's talk there, you know, in the longevity, we have a lady that contacted me 8-9 months ago. I want to come up and see, you know, I donated, I was the 4th donor at Columbia ever, and I want to just come see how transplants evolved in the transplant clinic. I said, sure, you can come up and I'll tour you around. She's going to come up in April for Donate Life Month. She was 21 when she donated. She's now in her 70s. So if that doesn't show you how well somebody can live with 1 kidney and go forward in life, and it's a very safe and controlled surgery. We don't take it very light. We have to be very strict on who we allow to donate, but we also have to be a little loose on other things. And when it comes to maybe the psychosocial part, we have to consider what would happen in the event that we ruled this person out and what they're going to do to themselves. So there's also not just, okay, we have to watch them after donation, but what happens if we rule them out and now they're going to go into a depressive slump maybe. So we also have to be, there's a lot of factors to take in when we approve a donor.
Brian, why don't you, while you're approving the donor, tell us, in fact, if I am a patient and I have found a donor, what do I have to do next? So I will call you. And what are you going to tell me?
Well, we've put into effect, you don't even need to contact us on the donor team. You can, we will get back to you or answer the phone if we're there. But really, a donor wants to come forward, they go onto our website, and there's what we call a donor questionnaire or an intake form.
What is our website?
Our website is columbiakidneytransplant.org, all one word. And it brings you right to the kidney pancreas transplant website. And that's for recipients as well. They can register on there to be a patient with us. And then there's a little tab on there that says, I want to donate. They click it and it's a donor. Essentially, it's just a questionnaire, a 2-page, takes 1.5 minutes to fill out your demographics, your brief medical history. And from there, that goes to the nurse coordinators on the donor team, and we review those. And most of the times they're approved to move forward, but some things in the medical history might automatically rule them out, such as diabetes or being on 2 or more blood pressure meds. So again, we tell people, just fill it out. Let us look at it and rule them in or out. And so then if they're approved, we then test them with the recipient that they would like, or if it's an altruistic donor, somebody that just wants to donate to anybody, we would just move forward. Instead of testing with somebody right then and there, we'd move forward with their evaluation, blood tests, coming in and meeting the team, a nephrologist, a surgeon, a psychiatrist, a social worker, a financial coordinator, and do a CAT scan, chest X-ray, EKG, depending on the sex, mammogram, pap smear.
So, what about if I have a donor who lives abroad?
So Dr. Hardy, before we go there, because I think we have so many questions from the audience, I just don't want to miss them. There's a person here who's asking Brian, I think you described very well the process. They're kind of trying to get the timeline for it. What do you think is the average timeline for getting those tests in from the moment of you have a donor, you're ready for the transplant, to being on the table?
It varies, okay, because it can depend on the age. The younger the donor, the less tests they may have to do, or maybe we find more things when they come in and get evaluated, and so we have to add on tests. But on average, it's around 2 months. You know, of course, we strive very hard to like narrow that down. You know, if we can, whether it be call Dr. Sandoval or Dr. Ratner or Dr. Morris to say, hey, I have this donor. The recipient's almost on dialysis. We need to move, like, you know, lickety split. Can you open up an extra clinic day or slot? And Dr. Morris or Dr. Sandoval will see it. So, but on average, it's around 2 months. And then you run into, it can be a lot longer too, because the recipient has a lot of testing they need to do. And that can drag out over time. So that could also prolong the process. So it's kind of twofold. I can work a donor up very quickly and clear them, but maybe the recipient's not ready, or maybe now's not the right time because their function's still too good. So it's good that we got the donor at least cleared and they know they can donate, not ruled out.
Good. And I'm sure also you try to very quickly assess whether it's not a good donor, so that person can go
Yeah.
and find someone else.
Yeah, I mean, that's the one pain in my head in my heart I always have, is like, I want to let this person know as quickly as I can, whether it's on donor questionnaire or later in the game, that, look, unfortunately, you're not a candidate. Let's tell the recipient, so the recipient can have any other donors test or that have tested come forward. And sometimes it comes out at the very end, and whether it's a CT scan and we find out they have one kidney, would it have been better to do the CT earlier? No, not necessarily, because you can find anything out at the end. And unfortunately rule them out. That's just the game we play. But again, most donors are healthy individuals, and that's what makes it very easy to get them through a workup very quick, because you don't really find too much. And just to say, everybody really wants to know the risk of surgery and the risk post. We say on the nursing side, when we evaluate a donor, what's the risk of a donor evaluation? Well, you guys want to know the risk of that? The risk to you as a donor, there's not much. There's no real medical risk other than finding out you have something you didn't know you have, whether it's cancer. But again, that's not really a risk. We're doing $1 million workup on you.
That's
you might find
prevention.
something. Yeah.
Or early diagnosis.
I can comment if you want on Dr. Hardy's question about overseas donor or out-of-state donors. So out-of-state donors shouldn't prevent them from coming forward as a donor. We have the ability to reach out and do evaluations virtually if they're in different states, do at least the basic blood tests to begin with, but eventually the donor will have to come here. If they're international, we have a policy here at Columbia that they have to be either a direct relative, mother, father, kids, brother, sister, or have a very close connection with the recipient. Okay, and we look into that very strictly here. If we have an international donor, we'll have them see the psychiatrist and the social worker first virtually to see if they do have a connection to this recipient. Because again, we work in a field on the donor side that some people aren't very truthful when they're coming forward, and sometimes we get this funny feeling, this red flag that we have to follow up on, and it's hard to prove a donor's being paid or a donor's being coerced, because that's completely legal and should never happen, and we will stop a whole eval if we find that out. But they have to be careful with international donors. Yeah, of course, they live in the same town or the same village, okay, and they say, oh, that's my brother. Well, we know in little villages in the island of the Pacific, I know because I've been there, everybody's your brother, everybody's your mother, everybody's your father, and that's great. We just have to be very careful and make sure that the donor is coming to us and calls us or contacts us and say, I want to do this, and not from necessarily the recipient, even though the recipients are trying to help. Sometimes it can be a little red flag or a little hindrance at times. Donors cannot be paid to donate. It is illegal. It is a federal crime. You cannot, get into the fields of human trafficking and things like that. You have to be very careful. Think about it. If we get shut down because we missed that, maybe the donor got paid or human trafficking happened and organ trafficking happened. If we get shut down, it's not just that recipient and donor that are affected. It's everybody. Hundreds of thousands of patients at Columbia will no longer get a transplant for maybe a short period of time, depending on if we could reopen, or maybe we're shut down forever and everybody's then got to go somewhere else. So it doesn't just affect one people, it affects everybody. So we have to be very careful.
But the international donor can actually get on the same website that you mentioned and fill out their form. And after that, you can direct them to their own physician and get some of the basic blood tests, find out if they do have 2 kidneys over there, not wait for here. And at some point they will have to come, but they don't have to come early on. And they generally do not have to come twice.
Correct. They will do pretty much almost, I call it a double workup. We'll have them do a bunch of stuff and say, maybe they're coming from South Korea. Hey, go do all this ultrasound, blood work, everything. And then when they come here, when we get all that, it looks okay, then we help them, you know, we'll write them a US Embassy letter to help them get a visa. If they can get a visa, they'll come here. And they're going to repeat a lot of the same stuff. But it's still, you know, CT scan more in depth, where over in South Korea, they'll just do a kidney ultrasound and make sure they have 2 kidneys. So we look at that because, again, we don't want to waste their time. We don't want to waste the recipient's time either, or the donor's time and money flying here when we're not going to consider them.
Right. Dr. Hardy, I think we've reached time. We have a lot of questions here.
So go ahead, ask the question. So ask a few more. We can
Yeah.
stretch it a little bit.
Yeah.
I can answer a few questions that I see, if you don't
Okay.
mind me
Go ahead.
jumping in.
Yeah.
So there's a
Quickly.
couple of things that are quick, I think. One, someone asked 2 months to clear or to get back in touch. So again, this 2 months, I think it's kind of like an average, you know, Brian is putting out. So a lot of the time that is going to take is driven by the recipient, which typically takes longer to do the entire process. They need more care, more studying, and so on. If we're talking about a donor that comes after the recipient is ready to go, it usually won't even take the 2 months, you know, and especially if they need the transplant soon. Let's say we want to try and do it before the patient hits dialysis. We want to move forward. Sometimes we can push it through and do it in a few weeks, the donor evaluation. Matter of fact, in the international donors, we tend to do that. You know, they travel in and we have everything stacked together. We do a comprehensive workup very quickly so they can have the transplant, recover in a reasonable period of time, and go back. So again, a lot of the time, the timeline is driven by the recipient more so than the donor. The donor, of course, is who drives the scheduling, meaning so a lot of times the donor has constraints in their own life. They can't do it in certain periods of time. They can't do it only after a certain period of time. So they will drive at the end when the transplants happen. A question, a donor approved and the recipient receives their gift from a deceased donor, can the living donor still be able to donate? Absolutely, yes. So, and we have had a lot of that in the past. So donors, for whatever reason, have completed their workup and end up not donating, the recipient gets a donor, the recipient, for whatever reason, is not gonna use this donor, they can still donate and we can still make that happen. Is it possible for a person that been treated for cancer be a living donor? It is possible. So that we'll analyze in a case-by-case basis. So that cancer is a very broad term and there are different types of cancers, but we certainly have utilized donors that we have felt that the chances of recurrence or the chances of cancer remaining in the patient is extremely low. We have used them in selected cases. There was also a couple of questions that I thought that were important that came a little earlier. Someone said that has multiple donors. If one has high blood pressures, is that one gets automatically ruled out? Not necessarily. So, you know, and this is very general, but of course, if we're talking about 4 different donors that are very similar in age, why not in the relation to the patient, but one is hypertensive, the others are not, we will lean towards the others, obviously. But the fact that the patient has the potential donor has a history of hypertension does not automatically rule him out, but it will have to be assessed in a case-by-case basis. Sometimes we can utilize donors that have had a history of high blood pressure that are well controlled, that are not difficult cases to control in terms of their high blood pressure. And the last one that I wanted to really quickly address is someone that a parent to a child. I think that comes really close to what I do, since I do some of this kidney transplants in pediatrics, and this comes a lot. What is the best donor for a child? So is the parent too old for the child? So rarely the parent is too old for a child. So I think those are typically very good donors. If someone younger can donate, not necessarily is a better donor. So also we will look at it in a case-by-case basis, but usually a parent to a child, that tends to be a very successful type of transplant.
Can I just interject one thing, the basic question that I asked originally about a mismatch of a living donor? And I said there aren't really. Well, the fact is that any donor that shows up that is physiologically or has 2 kidneys and is healthy, doesn't have cancer, heart disease, lung disease, and so on, is a potential donor. So if they have the wrong blood group, they are called mismatch. If the recipient has antibodies against the donor, they're considered a mismatch. But those are the only 2 really considered mismatches. And under those circumstances, we have the option of doing something called a swap. And perhaps Heather can comment very quickly on what a swap is.
Sure, no problem. So a swap is if you have 2 pairs of donor recipient combinations where each is in the same boat, and you have, let's say, a blood type incompatibility in one pair and a blood type incompatibility on another pair, you can have the donor swap. So one donor can donate to the other recipient, and then the other donor can donate to the recipient that was not their intended recipient. So you just swap. It's basically exactly like what it sounds. Is that what you were?
Yes, and it's done on the same day in 4 operating rooms. So it's all done at the same time. That's one possibility. The other one is with the antibodies. So it is relatively rare for a husband to give to a wife as compared to a wife giving to a husband. And the reason that the wife doesn't give to a husband, that the husband doesn't give frequently to a wife, is because the wife may have antibodies against the husband, and frequently does if she has been pregnant with the husband's sperm. So that and the ratio is about 1 to 7, husband to wife donations. Mm-hmm. And if that is the case, so if the husband wants to give, but the wife has antibodies against the husband, that husband can give to someone else, and then that you can swap that way. And that applies also to people who had previous kidneys or had blood transfusions, or who just develop antibodies against their donors. And in those circumstances, we can, in fact, do the swap successfully. And the swaps can be sequential. So you can actually do 2, 3, 4 swaps at the same time. And in order to make everything balance out. It takes a little extra time to identify donors and recipients, and that's where the coordinators actually juggle everybody's time and availability. But that's a very important consideration, because the excuse that someone is mismatched and therefore cannot be a living donor is no longer an excuse. Mm-hmm. It is an unacceptable excuse.
You know, that's something that people are very much following, of course, media. And I do think that I know that there is now a company that is advising essentially Hollywood, or advising movie companies and TV shows and so on, because there's so many dramatic scenes where there is a mismatch and a person is left without a transplant.
Oh yes, this is a terrible misnomer.
Yeah. Yeah, but
Yeah.
it's all over, and I think that's almost you know, not an obligation, but it would be a great campaign to be maybe run by a transplant organization to try to convert that, because it's
Well,
terrible for the
this is
audience.
why I addressed this question, because there was actually among the questions that I pulled up here. So one member of the audience asked this exactly that way. So many people, potential people, get told they aren't a match.
Yes, yeah,
They are. Everybody is a match if you're willing to swap.
yep,
There are people who do not want to swap. They don't want to give it to somebody outside of their family, but that's actually turns out to be relatively rare.
as long as their family gets it from someone else, I'm sure.
That's right.
Yeah.
Certain blood types, I will say, are very difficult to swap. And
Yeah.
when we tell a donor, hey, look, we got your matching back. You're not a match. You're not a blood type match. But good news, there's somebody else that tested is a match. So then they know, okay, at least I don't have to maybe consider the swap. But we do get certain recipients that have multiple donors and none of them match blood type wise. We educate the donors, okay, on what the next step would be if they still want to try to proceed forward, whether it's swap or an incompatible blood type transplant. But again, like Dr. Hardy said, they have, a lot of them wanted to donate to their intended recipient. If they find out they're not a match, they're not going to move forward, and that's their right. So as a recipient, you have to be kind of mindful of that, respectful of that. Other times, you know, there are donors that, and I want to put this out there, you know, I see the social media questions coming through, and I'm a huge campaign advocate for social media because it's great. If you get your story out there, we have tons of altruistic people and they just keep coming to me. They keep calling. Oh, I heard from so-and-so who donated. I want to do it. You know, so it's word of mouth. But you do, as a recipient, put your blood type on there. I see that question there. So you can find that blood type person. But if nobody is your blood type, yeah, we can look at swapping. But please understand that there are the altruistic people out there on social media that will want to test, and they believe it's very difficult to match. So they'll just do it and they won't come forward. Finding out when they are matched, they're like, oh, I didn't know that. So then they may not proceed forward. So it's not to discourage you from social media, but understand that maybe out of the stack of 100 donor, you know, questionnaires we get for you, 25% of those may proceed forward. It's just the nature of you know, human beings and how we are. But the altruistic donors are out there. They come to us like crazy and they start chains.
So,
And yes, social, you know, the movie and things, please don't watch those shows and go, oh, that's how it is. That's not the education you need, because I've lived this for so long and I won't watch medical shows anymore.
that's why we have these sessions.
So
I just want to, as we come to the end, I want to thank our panelists, Dr. Sandoval, Dr. Morris, and Mr. Runge. We're delighted with our audience and their questions. We are available to answer these questions after this show ends. And I just want to announce that on March 16th, we will have the next session, and that will be really led by Dr. Chang, who is a nephrologist, Dr. McCune, who is a surgeon, and one of our panelists will be Maxine Morris, who is also a major coordinator. And the questions that we're going to be discussing: what does a patient have to do while waiting for a transplant in terms of maintaining their health and their awareness and their contacts with the unit? And we'll focus more on the actually deceased donor workup and donations. So thank you all for being here, and I thank my co-moderator Dr. Hechenberger, and we again thank Veloxis for supporting this effort.
Thank you
Karen,
so
say
much.
goodbye.
Thank you, everybody.
I'm so glad I get my instructions. So thank you so much, everyone. And I also want to say, both as CEO of Lifebowl, but as a transplant recipient, I want to thank the doctors, the nurses, all the people who do so much for us. But I also today want to thank the living donors, who are really doing such a big service and are literally giving us life back. So thank you so much to all of you, and those who consider doing it. I think you're going to feel great, and you're going to do wonderfully. So thank you, and we'll see you in a month. Bye-bye now.
Thank you.
Thanks.